Thank you, Roxanne, and thanks for the invitation to be here. So I'm not going to do a tour de force because there happened a lot within the last year in the transcatheter valve therapy. I'm just going to focus on 3 topics. One of the evidence we have this year, one topic where we certainly need evidence, and then also at the end, what we have seen in new technology development. So these are my conflict of interest. So we already heard about this cerebral embolic protection. That's probably the most important evidence we have seen in 2022. Should we use this as a routine in patient undergoing TAVI procedure? And if you talk with these patients undergoing a TAVI procedure, these elderly patients often, they're not as much afraid of dying, but the biggest concern is they're going to have a stroke, which is going to make them disabling. So I think a few of us have used this routinely without any evidence whether it's actually going to reduce the risk for stroke in patients undergoing TAVI procedures. So this year we saw PROTECTED-TAVR coming out, quite large-scale study, 3,000 patients randomized to TAVI using cerebral embolic protection with a sensor device or just TAVI without. And it was a quite pragmatic design. Patient had a neurological assessment before the procedure and before the patient actually left the hospital. So the primary endpoint was all stroke at discharge or at 72 hours, whichever occurred first. And we saw that the trial was neutral. There was a numerical reduction in all stroke at discharge after 72 hours from 2.9 to 2.3%, but not significant. On the other hand, we saw there was a significant reduction in disabling stroke from 1.3 to 0.5%. But again, this was a secondary endpoint and we missed the primary endpoint. But I think that's quite a lot of information in this trial. First of all, you can see that the stroke rate is quite low nowadays. It's only about 1.3% of the patient who's going to have a disabling stroke after TAVI. But also that the stroke rate was actually lower than predicted. In the trial design, it was expected that in the control group, the rate would be 4%, and in the test group, it would be 2%. And you can ask yourself, why was it? Because patients maybe were selected for that. Patient who had a higher risk was treated with, the sensor device was used outside the trial because it was commercially available both in Europe and the US. You can also ask yourself whether, the second thing you can look at this is, look at if you see that even though it's small numbers, patients having the device have a higher rate of disabling stroke, but a lower rate of non-disabling stroke, but a lower rate of disabling stroke. So maybe these fillers not completely remove the rate of stroke, but they're likely to transform a disabling stroke into a non-disabling stroke. So there could certainly be some benefit of using this. So how are we going to move on? I think we have already heard that there's another trial going on in the UK, the British Heart Foundation PROTECT-TAVI, even larger trial, 7,700 patients, very similar design, one-to-one randomization between sentinel and no sentinel, similar endpoint. And I think that one of the very good things about this trial is that in the UK, the sentinel device is not reimbursed. So that risk that the sites are going to treat patients with the device outside the trial is much lower. And also there's also already a pre-specified meta-analysis combining these two trials is going to give us almost 11,000 patients to see that whether there's actually going to be a difference between these two therapies. So, and also there's a limitation of this because remember that the device is only working those 30 minutes is actually inside the patient, and the endpoint was up to 72 hours afterwards. And also as we're going to move to patient at a younger age, I think these silent brain lesions maybe not be as silent. If you ask a stroke neurologist, he's going to say that it's going to put the patient at risk for cognitive impairment and early dementia. So I think there's certainly a lot of things we need to learn about using these devices. So moving from the evidence to where we need evidence. These are the American guidelines from 2020. You can see patients are divided into 3 groups. Younger than 65 should go for surgical aortic valve replacement. Older than 80 years of age, TAVI, and then you have the group in between. And when I saw these guidelines, I think it may be even quite aggressive because I don't think it's supporting to go down to 65 years of age from the low-risk trials. I think 70 years of age will be more reasonable. But then we saw just last month, this is how it looks in the US for patient undergoing isolated aortic valve replacement. And you can see for the elder group, according to the guidelines, so they should have TAVI, it's almost every single patient who's going for TAVI. In the group in between 65 and 80 years, where you should consider TAVI or surgical aortic valve replacement, it's now almost 90% of the patient who's undergoing TAVI. And even in the younger patient, younger than 65 years of age, where surgical aortic valve replacement should be the first option, it's half of the patient nowadays in the US who are treated with a TAVI procedure, again, without any evidence. And if you look at patients at that age, younger than 65, you know most of these patients will come forward with a bicuspid and another tricuspid aortic valve. And remember, these are completely different phenotypes, and also these patients never went into the randomized trial comparing surgical and transcatheter aortic valve replacement. Despite that, both Edwards and Medtronic got approval for using their valves in patients with bicuspid aortic valve. And if you look into the evidence, what is actually the evidence for doing TAVI in patients with bicuspid aortic valve? This slide summarizes all the evidence. And you can see most of it is small trials, and almost all registries are based on patients at an older age and high surgical risk score. There's very few patients in the bottom left corner, younger age and low risk. And also, if you look, what evidence do we have on TAVI versus surgical aortic valve replacement in bicuspid aortic valve? There's only 4 studies, all retrospective study, again, in patients at older age and higher risk. And if you look at prospective studies, that's no evidence. Also, if you look what kind of patient was actually treated, we all know that bicuspid valve are very different, could be type 0, type 1, and type 2. And it's for almost 80% of the patients in these registries, it's not even reported what kind of bicuspid aortic valve the patient had. And look at the follow-up. When you exceed 1 year, there's almost no follow-up data on these patients here. So again, we strongly need to see a randomized trial comparing surgical and transcatheter aortic valve replacement in patients with severe aortic stenosis based on a bicuspid aortic valve and at a younger age. So finally, we have seen some technology development. We know that quite a large proportion of patients with aortic valve disease have aortic regurgitation, not aortic stenosis. It will be around 1 out of 10 patients who's coming forward with a pure aortic stenosis, regurgitation. And the issue is for these patients, there's often no or very little calcification. So anchoring of this transcatheter heart valve with radial force is very difficult. And I can just show you one example here, a patient we have treated, and I think everyone who has treated these patients with TAVI have seen the same, that what's going to happen is the device is going to embolize into the left ventricle. And for this patient, what actually happened was that the stent frame cut through the anterior mitral leaflet, and the patient had to go for double valve replacement, surgical valve replacement here. So we have seen now, I think that is probably the most important technology development we see this year, is the approval in Europe of the Jena valve. I know it's going to be approved in the US soon, hopefully. It's going to anchor on a very different mechanism. It got these 3 paddles or arms, which is going to sit in each of the commissures to preventing it to embolize or migrate into the left ventricle. And this is just here after, okay, it wasn't one, but after final deployment. And one additional advantage of this Jena valve is it's going to automatically give you commissure alignment and thereby easier access to the coronary arteries and maybe also better durability. I think I'm going to stop here and we can take the discussion from here.
Excellent. Wonderful. Thank you. Please join us.